Welcome back to the Tom and D podcast. My name's Tom Fry. This is Darren Abram. And does it look different in my background today?
Yeah, what happened to it, man?
Well, one of the things that I was getting, people don't know I'm selling my house. But one of the things, like my ceilings had some cracks on them, like small, just cosmetic cracks, but they were telling me that, people would look at it and say, I'm not sure, is there some structural damage, anything. And then while I was having these 4 ceilings redone, I decided to paint 3 of my rooms that were darker colors. So this room, as you know, was kind of a terracotta tile. My bedroom is kind of a bluish color. And then my back room, my family room, is a dark red. So now those are all shoelace white, I think is the color they call it. So,
well, dude, that story is as exciting as probably watching the paint actually dry.
It is.
Tom and D.
2 middle-aged idiots. Now, you were mentioning last time we talked about your son going to Australia. Is he still involved in that, or what's he doing?
Yeah. He's got his tickets, I believe. At least he has his plans. So he's heading out there in January. And
wow.
So hopefully I'll be heading out there a month or 2 afterwards to visit.
I hope he doesn't mind spiders, because they have these huntsman spiders that are literally bigger than my hand that my sister said get into the house sometimes, and you see him crawling up the wall. So,
well, you have those Marco Rubio small hands, so it's okay.
No, I don't. I have a big hand. You know what they say, big hands, big gloves, buddy.
Big gloves, that's right.
So who's our guest today? Because I didn't bring one.
Okay, so today I decided to mix things up a little bit. All right, so we've had all sorts of guests on the show. We've had big name Hollywood producers, these famous artists that do Star Wars and pinups. We had a world marathoner, sleep hypnotherapist, and even your mom.
Yeah.
So it's we've had a good range of people. But again, today we're mixing it up a little bit. And the reason why we're mixing up to this subject matter, and I'll get to that in a minute, our guest, but it's primarily because I'm working on this project, can't go into it in too much detail, but it has to do with this messed up world of health insurance and pre-approvals and why a fucking Band-Aid costs as much as a used Honda. So
hey, I drive a used Honda.
I know.
You're telling me that a Band-Aid is worth
it's got Band-Aids all over it too.
It has Band-Aids all over it.
Right. So today is a little bit different. Our topic's a little more serious, probably. I don't know, but we're a couple of idiots, so we'll probably not understand half of it and try to just laugh our way like Beavis and Butthead.
Right.
But anyway, this guest, he's a doctor, but he just doesn't hand you a prescription and send you on your way. Nope. This guy, he actually talks to his patients. He listens to them. And get this, he actually makes decisions with them. And I know because I'm actually a patient of his.
Wait a second. He's your doctor.
He's my doctor.
So this is probably one of the few people in the world that have had his finger up your butt.
Well, one of many. one of many.
Well, that's what we'll focus on. We'll ask him lots of questions about your prostate. Can we get some prostate info?
Thanks to HIPAA laws, he probably won't be able to divulge that. So
thank God.
Anyway, he's the kind of doctor who believes that medicine isn't just about fixing the symptoms. It's about knowing who you are as a patient, as an individual, as a person. He knows all about you, your family. He spends a lot of time with you. When you go in to see him, you actually see him and not just a PA or somebody.
Right. Yeah. Usually someone comes in, does your blood pressure. Someone else comes in, does this, and the doc comes in the last 2 minutes and then's out.
Exactly. Yeah. So without further ado, the man, the myth, Dr. Michael Keller.
Oh, well, thank you for that kind introduction, Darren. I really appreciate it. That's very kind of you.
That was a nice introduction.
Yeah, I mean, I can't say enough great things about you, really.
Well, thank you. That's very, very kind.
Well, and you're wearing a black what do you
I'm
call
wearing my
that?
scrubs.
Black scrubs. So, it's almost like you're this fucking rocker.
Little Johnny Cash.
There you go. Man in black.
Well, Dr. Keller has, again, he's been my doctor for, I don't know, maybe a decade longer, I think, probably
I
closer
would
to
think
15
longer.
years.
Yeah.
Yeah. And my entire family. And, one of the things that's unique about your practice is, you weren't assigned to me through my insurance company. As a matter of fact, you don't take my insurance. As a matter of fact, you don't take any insurance.
That's right.
You are, if I got this right, it's not concierge medicine, or maybe it
Right.
is, but it's direct primary care. Is that correct?
Right. Yeah, that's the right term. Direct primary care is nicknamed concierge for the masses. Basically, in a concierge model, the docs continue to accept health insurance, and then on top of that, they bill patients a premium, and that premium allows you to have longer appointments, or earlier appointments, and you might typically have that doctor's cell phone number, or there's greater access. But concierge is typically much more expensive. Doctors have smaller panels. In direct primary care, we just eliminate insurance. Most of our patients have commercial insurance. We just don't accept it. We don't bill insurance. And that's what allows us to lower costs in the practice, and make it affordable for patients, and provide better care, get to know our patients better, and so forth.
Well, I'm with Kaiser because my dad was a retired Kaiser doc, and he directed me in that direction. But I mean, I pay like $30 or $40 to see my primary care physician. Granted, I'm not getting the one on. I mean, you just heard me talking about that, but I mean, like, what would an average appointment cost? I mean, I'm just wondering how you make it affordable for the patient.
But wait, before you answer, it's not just $40, because you're also paying your monthly premium too on top of that, right?
But I still have to pay for my premium, wouldn't I? Because just in case I have a catastrophic injury or something.
Yeah, exactly. I mean, really, direct primary care is patients pay a monthly fee for essentially primary care services. And given that, honestly, 80% of what happens to a person in their lifetime can be managed in a primary care office,
Sure.
That's really what you need. But you're right, Tom, you need backup health insurance in case you get hit by a bus, or you get diagnosed with cancer, or you need your appendix taken out. I mean, you need the insurance for that.
Right.
But essentially, the model works by, for example, you pay a monthly fee. It's like a gym membership. You can use it or you don't have to use it. Sometimes, patients need the care, frequently, whether it's through phone calls, emails, telehealth visits, or office visits. And other times, they go months without using it. But for example, we chose not to charge a copay for any office visits because that's a barrier to good primary care, right? And same thing, we pay for our patients' basic labs. We just don't think it's worth getting into billing their insurance for things like that. And so we wanted to create a model where, not only did we know our patients, but there weren't barriers to you coming back to get your blood pressure rechecked and so forth. In a direct primary care model, patients tend to see their primary care doctors 4 to 5 times as often, or interact with their primary care doctors 4 to 5 times as often as in a traditional fee-for-service model.
And that probably allows you more time, I'm guessing, to practice actually doing medicine instead of and treating your patients instead of dealing with insurance. But how does that affect you with the amount of time that you spend as a doctor?
Yeah, that's how, that's really how the direct primary care model was born is, and this goes back, I think, maybe 30 years now, that the doctor, and I'm going to blank on his name, but he was in North Carolina. And he noticed that when he went to work for a primary care practice, how much time, effort, and money and personnel were spent just trying to get paid by insurance companies. And he said, if we didn't have this, we could actually make this care much more affordable, because primary care is considered a low cost specialty. We don't use expensive equipment, lasers, operating tables, and so forth. And so if we just don't have these extra costs, we can make this affordable. And so when he was able to get rid of those people that spend their entire day billing insurance companies, then he realized, hey, this actually allows me to see, 5 to 10 patients a day rather than 25 to 30. And of course, all the good things that happen after that, where, we get back the joy of practicing medicine. Number one, getting to know our patients, and number two, being able to think during an office visit, because we all enjoy practicing medicine. We just need to have more than 10 minutes to do it.
You actually spend time. I'm sure you review your notes and be like, okay, who's this guy again? But you're like, how is so and so? How's so, and the family, and and you there's that consistency and that continuity, I guess is a better word, of
Mhm.
understanding why you were in last time and years
Right,
before, and like, wait a minute, this thing happened, as opposed to, again, getting a different physician that might be
right.
assigned to you, or a PA or something, that where they may not know about that previous thing, and
Yeah,
so I don't have to go back and tell them that. That's the reason why I get my haircut at the same place. It's like, I
yeah,
don't
that's it.
tell them, what's going on.
I
Why you use the
honestly,
same? It's why you go to the same massage. The happy ending place, that little Asian massage parlor. Yeah, because they know what you
Exactly.
like,
They
Darren.
they
They
know
know
what
what
I
you.
like.
They know what you like.
yeah, and they
Ah,
can and they can speed it up.
Right.
Um,
ah.
Yeah, I honestly don't know how you practice medicine without knowing your patients. I cannot even imagine the concept of walking into a room and not at least asking somebody a little bit about who they are. What do you do? What are your passions? Who lives at home with you? Who's your family? It's so much more enjoyable. And honestly, I mean, it primary care is so critically important in the healthcare system. And partly, if you have good primary care, what you've really done is you've added a person in your life that actually cares about you, which all of us could use. Adding one more person to our life that actually cares about our mental and physical and spiritual well-being. But I don't know how you do that if you have no idea the person that you're walking in and recommending any type of
And it's
treatment
not
for.
even that hard. I mean, my dad told me that, when he's got someone's chart and he's, the first time he meets you, he says, hey, so tell me about yourself. Well, I'm a voice actor, and he writes down voice actor. I grew up outside Detroit. I'm a big Detroit fan. He writes those things down, and then before he goes in, he looks at it and say, oh yeah, this is the guy that's the voice actor from Detroit. So he comes in and he says, oh man, the Tigers are having a good season. Yeah, they are. How's the voiceover? Have I heard you on the radio lately? It's like, boom, this guy, all of a sudden you feel that connection with him, and you feel like that he really does care about you.
Yeah, absolutely. And it actually makes patients more comfortable. They're more willing to talk about issues that are bothering them. So, yeah, this model works great for everybody. It really does. It works. It's doctors provide better care. They can make a living providing better care, and patients get better care.
So
It's
is
kind of
this a trend? Do you see this as a trend where
well,
more and more patients are gravitating towards this, and more practices are moving towards this model?
Y- yes and no, right? On the one hand, this is one of the few sort of innovations in healthcare that has broad bipartisan support. And I think somebody told me this. I don't watch the news for obvious reasons, right? It's just so depressing. So but somebody told me that the big beautiful bill that actually contains a benefit for DPC, where I think either you can deduct the monthly costs from maybe your HSA. People have been doing that for years, but I think it made it official. So on the one hand, I think it's continuing to grow. The problem is that there needs to be a lot more of people like me, right? Because when I left my traditional fee-for-service practice, I had probably 2,500 patients in my panel, and now I have about 625. So, obviously there's, 1,800 people that lose their primary care physician. So there needs to be a lot more of us to make this work.
Wait,
And
if you only have 625, that means you average like 1.75 patients per day. I mean, you're going to get a lot more better care if you've only got 3 or 4 people on your, I'm sure there are days where you're full, but I'm saying that on average, I mean, that must a lot more personalized care.
Oh yeah, it's a
night
great
and day.
model.
Yeah.
And that's the thing is, I'm not a believer. You guys will find the longer that you talk to me, I consider Bernie Sanders as a moderate in my book. I don't believe in a 2-tiered healthcare system, so I don't like, there are direct primary care doctors out there that charge a lot more. But it's important to me, I love the cross section of Denver that I see. I like to see teachers and custodians, and, that's just part of what I try to do. But yeah, that's the problem, is that there's so few of us that, this could easily become medicine for the 1%. It's what I try to avoid in the DPC world, especially knowing that this model was really born actually to help the uninsured. And that's what that gentleman who started the model, 30 years ago in North Carolina, that was his intention, was, he saw all these uninsured patients, again, realized that the costs of running that practice was preventing this from being affordable for those folks. So,
Right.
So it's part of what you try to, keep in mind when you do this. But yeah, we need more people, and that's why it doesn't grow as rapidly. That said, medical students who are graduating, the way they view direct primary or primary care in general is as nothing but aggravation, right? Because they see that in the fee-for-service world, doctors that are frazzled, spending 10 or 15 minutes with a patient, all the paperwork, all the insurance red tape. If they knew a little bit more about direct primary care, there would be more medical students going into this specialty.
Are you calling it thief for?
Fee-for-service is the traditional
fee-for.
model.
I thought you said thief, and I'm like going, well, yeah, they are ripping me off.
Yeah, no doubt. No doubt. Yeah.
Well, Darren, you and I were talking the other day, and and I actually came up or heard a really good joke, and it happened to be about medical, and then you told me a medical joke. So it might be time for a comedy break here. Okay.
Sure. Why not?
You'll love this one, Doc.
Bear with us, Dr. K.
So this guy goes in for a vasectomy, right? And he gets the procedure done, and he wakes up, and he's like, well, I got good news and bad news. And he goes, well, the bad news? He's like, well, I accidentally slipped and I cut off your penis. He's like, Jesus. He goes, what's the good news? He goes, send it off to pathology. It's benign.
Well, to steal one from my favorite podcast that's out there, Smartless.
This is the only podcast, Darren.
If you don't do this one,
right?
Smartless, they're genius, but they often tell the same joke on there. I'll probably butcher it, but they always butcher it too. Luckily, I get to edit this, so I can shorten this.
Yes.
So he goes into his doctor, and the doctor comes down. The guy's got his pants down already, and he's like, all right, Michael, don't get an erection this time. And the guy turns around and is like, my name's Steven. He's like, no, I was talking to myself. My name's Michael.
That's funny. These comedy breaks are good.
Hey,
right, exactly.
You must have a good joke, a good medical joke.
Laughter is the best medicine.
Do you have a good medical joke you can share, Doc?
Oh man,
putting you on the spot here, right?
I know, and I'm trying to think of okay, what's the worst part of a lung transplant?
What's that?
Coughing up someone else's sputum.
Oh! That's a good one. I thought for sure there'd be a priest and a rabbi with the doctor on your joke.
Oh yeah, well,
a good one.
Bless my grandfather's heart. I'm sure he had a million of those that he told me, and I can't remember any of them. But
I'm sure. Back to being a little serious here. To your earlier point, do you think that by having that knowledge about direct primary care being taught at the university level, when people are in med school, do you think that exposure to that, or at least knowledge about that, would help alleviate some of that that misconception that's out there?
Yeah, I think so, and I think it is being taught to some degree. There's a little bit of a give and take on teaching medical students, right? Like I can bring a medical student into my practice, but it's not an ideal teaching environment, right? Because I spend a lot of time talking to my patients about their lives and not necessarily the nitty gritty of their health, right? And so it's not as good of a learning opportunity. But again, it's really about them seeing the model and how that works. A lot of medicine gets practiced during the course of my day, but it's just not as rapid fire. When they're in a primary care setting, one of the things medical students love is they get to see a lot of patients and they get to see a
Right.
lot of
If they're
pathology.
shadowing someone, they get to see 20 patients or whatever in a
Yeah.
day.
Yeah.
If they're shadowing you, they get to hear a lot of stories about their camping trips.
Yep, that's exactly right.
Right.
Yeah, that's exactly right. And it's obviously we need, there's 320 million people, right? And everybody needs a primary care doc.
Yeah.
I think I read recently that at least 100 million people in this country don't have a primary care doc, and that number gets worse. The percentage of younger patients, that don't have a primary care doc. So it
Yeah.
gets worse as we go along.
Are you an
Yeah.
internist or are you
Family medicine?
family medicine?
Yeah.
Yeah.
And to your point at the beginning of this too, about the cost and how much time you actually spend, getting care is from your primary care physician. I don't remember really the last time that I saw anybody else but you, except for, the occasional colonoscopy or something like that.
He goes
Uh,
like twice a week for those. He
yeah.
loves drinking that stuff
Right.
beforehand. He loves the taste of that.
Ex-
It's
right.
awful.
Oh man, we'll put some sound effects in here
Yeah,
after
please.
that
Yeah,
comment.
yeah.
Some toilet flushes,
Right. But I think I spend a little over $800 a month in my insurance for that I don't really use. I mean, God forbid I would ever have to. I'm glad it's there, but it doesn't really do anything for me.
Yeah, it's catastrophic,
Yeah.
that's what it is. Yeah, and I mean, and I have the same thing. I have Kaiser, and yeah, it's super expensive. And then when you get anything done, you just get billed for it, and it's like, well, what am I even paying for?
Right.
Everybody has to reach now these crazy deductibles to get anything covered anyway.
Yeah.
And then when they cover it, it's only like 75%. You're still
Yeah.
paying. If it's a $20,000 procedure, you're still
Right.
paying $5,000.
Oh, and then bills are wrong too. You get like, I just paid this, and you get billed for something
Yeah.
else. And it's like, no, you have to fight this. Moving away from that, getting into something that, I don't know, maybe a little bit more exciting in terms of at least being able to treat and apply, towards medicine. Do you see any like trends in treatment or testing or things like that that really excite you, or that you try to embrace and share with your patients, or maybe other fellow people in medicine?
Yeah, I mean, it's interesting. It's like there's all kinds of new things all the time in medicine. I mean, in this country, that's what we do best is medical innovation for sure. I mean, I'm on a committee at one of the downtown hospitals here. And it's a kind of a primary care outreach committee. So, and they took us into the operating rooms the other day, and it's like out of Star Trek. You know what I mean? And there's 15 monitors, and all the surgeries robotic. I mean, you could operate on a patient theoretically around the world with robotics. It's really incredible. So there's all kinds of innovation as far as that goes. There's a little bit of a dichotomy in the world of medicine, right? Where, we want to practice cost-effective, evidence-based care. We want to recommend things that make sense from a medical science perspective and not just spend money. And so, on the one hand, you have companies out there like, I'll just name one of them is the Function Health, right? Which is advertised all the time on podcasts all the time.
Dysfunction health.
It could be called that, right? This is an organization that you join for, several $100s a year. It's expensive. And basically they say, hey, we can do 400 lab tests for you. Well, patients like data. They like to get information about themselves, but the vast majority of these tests are not proven to improve your health in any way, right? So you've kind of got this movement in that direction. And then you've got, doctors that really are trying to be good stewards of healthcare costs and recommend diagnostics that are proven to be beneficial and treatments that are proven to be beneficial. I'm happy. As an example, today I saw a lady who has a knee injury, and I said we can do an MRI, but it's not necessarily going to change the treatment plan. So if we go ahead and try this treatment plan with some physical therapy, and we don't necessarily need the MRI. And she said that makes complete sense. And I love it when that happens because, that's something all of us need to do, doctors and patients, to make sure, we hold costs down and practice evidence-based care. So there, again, there's things that make sense. And then there's, times where it's like medicine for the 1%. And we could order every test that we have. I don't know that it makes a whole lot of sense.
Yeah. What about things with like, mushrooms or Eastern medicine or marijuana or some of the cancer screenings that are, with the blood tests? And I know I'm all over different directions there, and those are very different sectors.
Yeah, Darren, I could talk about the psychedelics forever. My dad was a deadhead, so this is a subject near and dear to my heart.
Yeah, you learned that medicine at a very young age.
Yeah, I mean, here's the thing. The thing about the psychedelics. So I just attended the Psychedelic Science Conference that was in Denver a couple of weeks ago.
Oh, wow.
And that was the original one was 2 years ago. This is put on by MAPS, the Multidisciplinary Association for Psychedelic Science. And MAPS does an amazing job. And this conference is the most incredible conference that I've ever been to. And in fact, the one in 23, we couldn't stop talking about it till this one in 25, And, the way that MAPS marries the science of psychedelics with the culture and the history and the mysticism is, just a beautiful thing, the way that they accomplish this. And there's not just physicians at this conference. There's of course other healers, therapists and whatnot, but there's, artists and historians and authors. And, it's really for all walks of life that are interested in elevating human consciousness through the use of psychedelics. And, thanks to Nixon, we lost 50 fucking years into these things.
Yeah.
And that's, that's our lifetime, right? So we're trying to play catch up, but I mean, obviously the loss of those decades, we're not going to get back. And the therapeutic potential of these medicines is, almost limitless.
It's funny when you said that, this is the best conference I've ever been to. I'm like, yeah, because in your welcome tote bag, there's a big bag of mushrooms. And they're like, have fun this week,
I'm sure all aren't the same. Like what is it? The lion's
Mane.
Lion's mane. I remember somebody talking about that. Like you try the lion's mane, but then I heard someone else like, no, you can only get like this type of it that works, because when you get it in this form, it loses its potency or it doesn't have any I'm probably misstating that, but
Well, I think what you mean is really sort of where you extract the mushrooms. If you buy a lion's mane supplement, any mushroom can be obtained either through what's called the mycelium of the mushroom, which is a little cheaper way to extract its active ingredients, versus the fruiting body of the mushroom, which is really where the bulk of the medicine is, right? And yeah, I mean, humans' relationship with mushrooms from a healing perspective obviously goes back to the beginning of time, and some mushrooms that are psychedelic obviously are going to have certain benefits, but lion's mane is a great example of a non-psychedelic mushroom that really deserves more study because it can help with focus and clarity. These things may have some benefits for dementia prevention. Um, but yeah. But yeah, the psychedelics are fascinating, and we're fortunate to live in Colorado. We passed Proposition 122. It's legal to possess psychedelic mushrooms. It's legal to grow them. And we're just getting up and running with what's called PAT in this state, psychedelic-assisted therapy. So, therapists are getting their licenses
Yeah,
to.
certifications. Yeah, I know that. My
Yeah.
therapist was telling me about this, It's kind
Hmm.
of like, certain, especially if people have some sort of a post, traumatic stress kind of a thing, or, anxiety, whatever it could
Hmm.
be. It's amazing that, how psychedelics are now entered into that realm of solutions
Right.
where it wasn't
Absolutely.
even there 10 years ago, unless you went to some shaman out
Hmm.
in, the middle of, some jungle.
Right. Absolutely. Yeah.
Yeah.
And all of us who have had psychedelic experiences, know that something is happening in our minds. And that I always think that Michael Pollan, the title of his book that he chose, that has really gotten so much of the public interested in psychedelics, How to Change Your Mind, was a brilliant title, right? Because these experiences are worth years of therapy to a lot of patients,
Yeah.
because they change the way they think, they change their perspective on their lives and things that happen to them.
He should have called it pollinate with Dr. Pollen.
Is there any sort of, I don't know, like warning that people should be aware of with that? Like, do it with the consult of your doctor, do it with a consult of somebody that knows,
Right.
instead of your cousin that sold it to
Yeah.
you from the
Your
back of his
cousin, his
I
van.
know.
nickname is
I know.
Acid Dave,
Oh,
not
I
the guy
know.
you want to.
Yeah. I mean, make no mistake, all of us in the world of psychedelics are plenty scared of what could happen, even as we want to learn more about the psychedelics and we want to bring them to people who need them. We are plenty scared because these are very, very safe medicines in terms of, you're not likely to die because of the physiological effects, but they're very, very powerful. And you're talking about opening up your mind and your heart in a world where there's a lot of bad shit going on in your brain,
Right.
and in the world, and you have to be cautious about this experience. So it's always talked about in the psychedelic world is set and setting, right? What is your mindset going into this experience, and what kind of setting are you in? And that setting should really include people who are not using the medicine, and people you trust in a safe environment. And that's one of the things you think about with, just like we talked about in primary care. We need a lot more of primary care providers. Well, we need a lot more psychedelic assisted therapists too, right? And so, this idea that you can just go out on your own and have a psychedelic experience and have it be therapeutic, that certainly might be the situation. But It may not, and the data that we saw at the conference a few weeks ago really supported the use of PAT, psychedelic assisted therapy, to help guide people through these experiences.
You
And
do
that,
need a guide, I think. I mean, even like
Mhm.
when you go into ayahuasca thing, there's always a
For
guide
sure, for
who's
sure,
not taking it, who can
right,
not only deal with the people who might be freak out a little bit. Now, ayahuasca
right,
is obviously a lot different than microdosing or, taking,
yeah,
mushrooms at a certain level. But yeah, you have to have a guide, especially
yeah,
if you want something to get something out of it, unless you're like the Beatles and just said, yeah, we came up with some great ideas for some
right,
songs.
right. Well, and it's interesting, Tom, that you brought up the Beatles, because that's one of the things that I think it was really not more than a couple of years after the Beatles spent time in India with the Maharaja.
Maharishi.
Yeah. And took a lot of LSD during that
Oh,
time. And
yeah.
of course, we all know what happened to the Beatles. I mean, it was almost a miracle what happened to their creative intents, and what happened to their music when they came back. It was amazing.
Yeah.
But it was really just a couple of years later that George Harrison was interviewed. And of course, the press was very hard on the Beatles at that time for their, drug use. And George Harrison said, look, we were just trying to expand our minds. And to be honest, I don't even know if that can be done anymore, because everybody has all these hangups and things that they're worried about. And that enters into the set and setting. Right.
Yes.
And so, again, we're in a time that, is to some degree troubled. There's a lot of thinking out there that's almost devolutionary, right? It's against human progress. It's against the evolution of human consciousness. So, you try to work the psychedelics into that world. It's not easy.
It's like you're going
And
to
I
have a
think,
bad trip if you go into it thinking I might have a bad trip.
yeah, for sure. And and that's why, there's a book out there, I think, Tripping on Utopia, if I can plug that book. And, it really talks about how the heyday of psychedelics was actually not in the 60s. It was really more in the 50s, when there was a lot more optimism about the course of humanity, right?
Right.
And, Timothy Leary may not have ushered in a new era of psychedelics. He might have effectively ended it.
Hmm.
Right. And of course, now this is another renaissance of psychedelics, thanks to people like Roland Griffiths at Johns Hopkins, and people who have done some great work, even when this movement was underground, which it was for 50 years.
Sorry about all the dings.
Yeah, what's going on?
The
We were
silence.
we were
Well,
joking about
like I said, I could talk about the psychedelics for a long time.
we were
Right.
joking about how sometimes prior guests have forgotten to turn off their phones, or whatever.
And then, of course, it happens to me
It
right
happens
now.
to Darren. We were just talking about it before the
Right.
episode began.
It's Annie telling me to pick up dinner on the way over.
What are you going to pick up? Something healthy if Dr. Keller's listening.
Yeah, I mean, one of the things at the conference, there were so many, I called them side quests that you could do during the conference, where you'd go into a room and there would be a sound bath that would be created, or they have all of the artists that create, paint, do video work, graphics work, under the influence of psychedelics, and all of that stuff is amazing. And people have realized over decades that again, goes along with that set and setting, helps create the right mindset, helps create the right setting. And the vast majority of people do report psychedelic experiences overwhelmingly positive. But your brain is very complex, and a psychedelic experience is not all rainbows and bunny rabbits. Your brain is going to take you to places that you've got to dig yourself out of. It's good for you.
I got kicked out of an Ohm tent. We were at this. It was so funny. We went to this party, and I mentioned the name Acid Dave because that was this guy that showed up there. And it was this party, my friend Maxim, he's a Russian guy, and he's giving around putting little drops in everyone's mouth, and And you know how you laugh hysterically when you're about an hour and 20 minutes into doing acid or something like that, or mushrooms, where you just, I went into the Om tent and everyone's going, Om, and I went, oh, and I was laughing so hard, they're like, get out, dude, you're ruining this whole thing. I did want to ask you about this, though. Darren's always giving me a hell, and, and my excuse to vaping is that, well, I'm ADHD, and people who have ADHD are like 100 times more likely to smoke or whatever, just because it's kind of like we need something to do. And that's not an excuse, but it's a fact. So I smoked cigarettes for years, and, I don't like the smell, the taste, the connotation that goes along with it. People look at you smoking, but vaping is so much easier because you can do it in your house. You can kind of hide it. It doesn't smell, whatever. But, obviously, and not enough research has been done to where we know exactly all the side effects, or, but in your mind, do you think that it's healthier than cigarette smoking?
Or has there been research
done?
No,
there hasn't been.
No. You'd have to be crazy to think that it's not healthier, right? Everything in cigarettes, right? That everything that was put with tobacco to, cyanide as an example, right? To make it more, to help it penetrate into your central nervous system faster and make it even more addictive.
Carbon monoxide.
All of those things, right? The only issue with vaping, and obviously vaping, these products, they continue to get more pure, so to speak. There's still some type of potentially harmful respiratory effect from vaporization that's not clearly understood, and so it's almost become like anything else, where it's, like my grandfather's quote, if I would have known I was going to live this long, I would have taken better care of myself. And then his other quote was, everything in moderation, right? So, one of the things about vaporization of nicotine is that now you can control the dose much more easily. So if you wanted to create a program where you could wean down your dosage of nicotine, it's easier than ever. But even though, we don't have a lot of direct data on vaporization of nicotine versus smoking cigarettes.
And I've had people tell me, well, have fun getting popcorn lung. Well, the popcorn lung thing was these people that were selling them out of the back trunk of their cars, and they had something else that wasn't sold like on the market now. This has like 3 ingredients,
Right, exactly. It gets more pure all the time. And
my asthma's better. I was telling Darren once, I said, one of the ingredients they use is in the nebulizers, when you have an asthma attack. I rarely have asthma with this, but I still do cough, and I still definitely am short of breath compared to, playing pickleball, running out of breath.
Right.
Much more than not smoking anything.
Yeah.
And it's the opposite effect. He's been over at my house and sneaks a little vape in once in a while. And I come into the room and cough, and he's like, nothing's happening. You're just faking it. And I have a hard time breathing. Like, it stinks and I can't breathe.
It smells like pancakes. That is not stink. Unless you don't like the IHOP. Do you not like the IHOP?
Dr. Keller, is there anything else that you think that people should know? Any big messages out there, even if it's just high level?
You brought up the cancer screening. That's an innovation that we were able to bring into the practice maybe 3 years ago, which is the Galleri test. The company is Grail that makes the Galleri test. This is sometimes nicknamed a liquid biopsy, right? And what the Galleri test is looking for is what's called cell-free DNA. All of us have these cells in our body that are dying, including theoretically and potentially cancer cells. So, thanks to brilliant advances, honestly, in molecular detection techniques, and then, really the power of these supercomputers, we're able to find these tiny fragments of cancer DNA in a blood sample, and then potentially diagnose cancer earlier. And I think, that's been one of the nice things to be able to offer I wish it was more affordable. It goes back to the insurance issue, certainly, but I think it's within reach for a lot of people. And the goal with cancer screening is to detect these things early when they're treatable, and not, we don't need another test that says you're at risk for cancer. We don't need another test that says you have stage 4 cancer. What we needed was a test that says you have cancer. Let's go find it, and hopefully we caught it in an early treatable stage.
And full disclosure, Grail was a client of mine, and I used to do the podcast for the Cancer Signal. That's the Galleri test. So I've heard a lot of these conversations, and it's my understanding that it doesn't actually detect cancer itself, but the cancer signal, these markers that are out there. So then it gives you a high likelihood that it could be,
Right.
in this range. So then that gives you information so that you can go get further testing to detect
Right.
that actual cancer. Did I sum that up more?
Yeah. I mean, it's
And maybe it's
looking
a
for,
nuance
it's,
for legal reasons. I
yeah,
don't
yeah.
know.
It's looking for, a very specific, type of signal on this cell-free DNA that might, and actually with a fairly high likelihood, indicate that you have active cancer. The positive predictive value of the Galleri test, meaning how often does a patient have cancer when they're found to have a positive Galleri test, is about 45%. Now that doesn't sound that great but in the world of cancer screening, 45% is great. That as an example, if a woman has a mammogram, she gets called back because there's a spot on the mammogram, they want to take a closer look. That finding alone, that has about a 5% positive predictive value for breast cancer. So when
Wow.
you start getting into 45%, this is a very valuable test.
As you know, I've taken that test,
Mhm.
and I remember waiting for the result. My thought was, on one side, it's like, wow, I hope it comes back negative. Of course, I want it to be negative. I
Yeah.
don't want to have a chance that I may have cancer. Didn't want that. But at the same time, it's like, I have that, and there's a
Right.
cancer signal there and it detects it. That's also good news, because
Right.
it means I caught it super early, and early detection is so key.
Yeah.
That's in my mind, the best cure for cancer that there is early
Yeah.
detection followed by early treatment.
Yeah, that's exactly right. I mean, basically, the vast majority of cancers are treatable if they're caught early. So yeah, and I think that goes back to our earlier conversation, which is it's just so important to have a doctor that knows you and that you go in for regular checkups. Obviously, we're just still big believers in that, and that alone gives you a higher chance of finding something in a treatable stage, even if it's not, even if you're not necessarily going to have a Galleri blood test and so forth. Go in, get a physical, get some basic blood work. Particularly as you get over, age 40 and 50, it's pretty amazing how often we find very treatable conditions. And extend people's lives and the quality of their life, really. So
You know what? I just to wrap things up. I mean, we couldn't let you go without asking you your thoughts on the Bristol stool chart. Is that a chart that you think that everyone should have, like on their wall? I mean, I just crack up when I see these on a doctor's wall. It shows like the hard poo and the
I
soft.
know.
The
Yeah.
Bristol stool chart, man, that is like the best thing I've ever seen in my life.
I honestly, Tom, the fact that doctors come up with this crap is,
Literally crap.
I'm like, I can't believe, I bet you dedicated how many meetings, with other docs to come up with this Bristol stool chart. And, I think 90% of us got handed that by, a pharmaceutical rep and just threw it straight in the
Right,
trash.
exactly.
Yeah, there's some of the stuff where you're like, I can't believe people dedicated their whole
Yeah.
careers to this.
Well, this has been great. We got to let Darren get some food. But Doc, man, if I weren't moving to Bloomington, I'd be, coming over to make an appointment.
Oh, No, that sounds great. And I really appreciate you guys. It's been great to be with you. Thank you for asking
Thank
me
you, Doc.
to come on.
Appreciate it.
Oh my
Yeah.
God. Yeah. Thank you so much. It's just a pleasure to talk to you. And, and it's the first time outside of the office.
Yeah.
Yeah,
Yeah.
that's true. That
And
is
his
right.
finger's not in your butt.
Yeah.
That's my own this time.
Well, thanks, gentlemen. I appreciate you very much.
Thank you,
Great.
Doc.
Thank you.
That was really cool. What a nice surprise.
It's such a nice surprise. And, because I think we talked so much about like cancer, especially towards the end and screening. I believe October is Breast Cancer Awareness Month. I may have that wrong,
I
but
think you may have it
there's
wrong.
going
I
to be
think that was,
something.
yeah, it was something. There was some
Yeah.
cancer
There's
awareness.
something like that. So maybe we'll time it with that. But
Yeah.
anyway, that was really cool. And I think, not only will people be a little entertained, probably more by him than us.
Well, I don't know. The Bristol stool chart was pretty funny.
That was good. That was good. But, maybe people learn something, and who
Right.
knows, maybe people
Yeah.
will go
Save a
in and
life. Maybe save a life.
maybe save a life.
Hey.
That's pretty cool.
Looking forward to the next one, buddy.
All
As
right.
always.
Thanks so much, Tom.
Later,
dude.
dude.
Tom and D.
Two middle-aged idiots.
This podcast is produced by 224 Media with voice and audio support by Fry on the Fly Productions.